bisphosphonate in CRPS. So we all know what is complex regional pain syndrome. It's a chronic pain condition which is disproportionate with respect to the inciting injury. Pathophysiology is a complex mechanism. There is central sensitization. There is the state of neuroinflammation. Along with it, we have autonomic dysfunction, motor dysfunction, and atrophic changes. Incidences are around 26 per 1 lakh persons annually. Females have a higher propensity, and we know there are two types. So let's discuss about the bone involvement in CRPS. Radiologically, we see there is regional osteopenia, state of osteoporosis-like state. There's subchondral cyst, there's juxta-articular demineralization, and there's an increased uptake in third phase of triple phase bone scintigraphy. So at molecular level, there is elevated nerve growth factor, the release of inflammatory cytokines, and there's increased osteoclastogenesis signaling. There's a condition of neuroinflammation and vasomotor changes with edema and local site swelling and temperature difference, all this. So here it is like in CRPS, we see there is an inflammation-driven bone turnover, which is not very classical of which is not very classical of osteoporosis. So, how is the mechanism of action of bisphosphonate different in osteoporosis than in CRPS? So, in osteoporosis, we have decreased osteoclastic activity. Thereby, there is increase in bone density. There's mainly a anti-resorptive mechanism going on, and bisphosphonates acts directly on the bone cells. Whereas in CRPS, there is macrophage and monocyte inhibition, there's reduced neuroinflammation, there's reduced production of nerve growth factors, there's it also prevents hydroxyapatite dissolutions, thereby having a anti-apoptotic effect on osteoblastic cells. So bisphosphonates, in literature, it is classified as a non-nitrogen containing and nitrogen containing. So in non-nitrogen containing, we have chlordronate. It acts via the induction of ATP mediated osteoclastic apoptosis. Whereas in nitrogen containing, which are also called as aminobisphosphonate, we have alendronate, pamidronate, neridronate, and zolendronate. It inhibits farnesyl pyrophosphate synthase. So, with the study, we have found that the nitrogen-containing bisphosphonates are more potent, are used frequently in CRPS, which I will be discussing in the succeeding slides. So, what are the favorable factors for the excellent response to bisphosphonates? So, we have the male gender, age less than 40 years, and lower limb involvements, early initiation of treatment, no other predisposing events, and early response if we have a initiation at like within 3 to 6 months, we have a better result. So, what are the unfavorable factors? Female gender, of course, in all the chronic pain state, as we all know, age more than 60 years, upper limb involvement, late initiation of treatment, and if there are other predisposing traumatic events and a delayed response to therapy. And if we initiate the therapy after 12 months, the results are definitely poor. So bisphosphonates, the advantages are they are effective for short-term pain relief, which are like 4 weeks to 3 months. Most results have shown it is effective during the short-term period, nor in the long term, nor in the immediate term. Number needed to treat is 2 to 3 for more than 50% pain reduction. It reverses hyperalgesia. It reduces allodynia. There's long-term benefit in longer study over 3 years. We have seen in the few studies, and they are generally safe. There is minimal or very like minimal serious adverse effect, and they are approved in Europe. One was neridronate, which is used as a the agent of choice for bisphosphonate for CRPS treatment. And there are multiple routes of administration. Limitations we have, like there are like short-term benefits are very less, and data more than showing the efficacy more than 6 months are very scarce. There's no difference in immediate period. There's high heterogeneity in evidence, and acute phase reactions are there, but they are manageable. And short-term RCTs, they have like short-term RCTs have a like small RCTs had there are only small RCTs to prove bisphosphonates, because as a good agent, because of the small sample size. Most CRPS, mostly the studies was done in CRPS 1 patients. So we have a limited CRPS 2 data. There are variable dosing regimens which were followed, and it is contraindicated in severely renal failure patients or renal impairment, and it is not FDA approved by US. So, dosage regimen, CRPS, in CRPS. We have neridronate, which is given as IV route, four injections of 100 mg given every third day, making a total of 400 mg. Also, IM neridronate, 25 mg daily injections for consecutive 16 days, total of 400 mg. Clodronate IV given as 10 injections daily of 300 mg per day. Pamidronate IV 60 mg, 4 injections given every third day. Alendronate is given orally, 40 mg daily for 8 weeks. So therapeutic window plays a major role here. If we give it in lower doses, definitely the results will be poor. So safety and adverse event profile of bisphosphonates in CRPS. So majorly we see acute phase like reactions in 40 to 50% of the patients, which are mild to moderate, and they are self-limiting. And the commoner side effects were fever, myalgia, and but they are not troublesome, and they usually resolve in 48 to 72 hours. Other side effects were arthralgia, GI intolerance, but serious adverse effects were very rare, like the osteonecrosis of jaw, because we have very few agents to show long-term effects, and literature has not reported very high dose of bisphosphonate to cause a very serious side effect like osteonecrosis of jaw. There is one recently published meta-analysis and systematic review by Michael C. Ferraro, proving the efficacy and safety of bisphosphonate in complex regional pain syndromes. The team included like 11 trials. Those were RCTs comparing various bisphosphonates with placebo. So they have found out that the bisphosphonate may reduce short term, which is like more than 4 weeks to 3 months, reduction in pain intensity in patients with CRPS, but this they appear to have less effective in immediate and medium term periods. Also, bisphosphonate may increase the risk of adverse events, but there's no very serious life-threatening adverse effects. And level evidence was uh, level 1, which was excellent. And this is also the same. The 11 RCTs were compared, and they've shown immediate term. There's no significant difference. Short term, it has proven benefit and pain reduction. Medium term, very uncertain. Based on the grade certainty assessment of this same study, short-term efficacy was moderate certainty because of the high heterogeneity of the population and some risk of bias. Long-term efficacy was very low because of insufficient data and short follow-up periods. Adverse event had a moderate certainty. Also, the study had some issues with the small sample size because they have included only 2,200 patients. The individual cities have included like a few patients only. And different diagnostic criteria were used across trial like Budapest or the ISSP, they have their own criteria. Variable dosing regimens. There was also co-administration, co-interventions like the physiotherapy and other medication, which was not uniformly controlled across the across the cities which he has included. Also, mostly the evidence is applied to CRPS 1 data. There was another study by Adami et al. In 2024, which was a longitudinal observational study in CRPS type 1 patients with IV niraparib. He has given uh, he has compared the naridronate group with the placebo, giving the 100 mg injections on 4 occasions, and he has compared the VAS score and also the hyperalgesia allodynia at baseline and at 3 months and 12 months. So I found, with the study, there was a mean VAS score pain reduction. Uh, Significantly, it was decreased at 3 months and later at 12 months. But in real life study, also there was a rapid and progressive improvement of symptoms of CRPS, which was it was maintained for 3 years of follow-up. So they have showed that the the excellent response to treatment uh, was uh, uh, was with the CRPS of lower limb involvement and male gender, and only if there is absence of predisposing events. There was another study done by Massimo Varina in 2013. It was an RCT comparing IV naridronate with placebo. So they included 82 patients with CRPS and they have given IV infusion of 100 mg naridronate over 4 days, over 10 days, 4 injections versus placebo. So they have seen the effect at 20 days, and after 20 days after like 50 days they have in placebo group they have given an open label of the same regimen of naridronate. So within 20 days there was visual VAS score decrease more in naridronate group compared to the placebo, but after following 20th day, meaning the 40th day, there was a vascular further decrease in active naridronate group versus the VAS score remains same in the placebo group. Uh, Also, they have provided the evidence that the use of bisphosphonate at appropriate dose is the treatment of choice for CRPS1. Another review was of pharmacological management of uh, 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 complex pharmacological management in complex regional pain syndrome, which was this was a review done by Kylie in May 2023. So they have studied that bisphosphonate could be considered as a first-line pharmacological therapy for CRPS. However, which particular drug, which at what dose and duration of treatment, route of delivery have not yet been standardized. So there was another review and a systematic review on uh, on the effectiveness of complex regional pain syndrome treatment. they have included the reviews of the RCTs from 1966 to 2016. So they have found that the bisphosphonate were able to show the uniformly positive results. And this was also like a major systematic review. Another meta-analysis was published in the Journal of European Journal of Pain, which was a systematic review of RCTs published from June 2000 to February 2012. So they have showed a number of treatment modalities were given. Out of the 10 treatment modality, the bisphosphonate have a role in three of the major treatment modality. So this was followed by there was another study on the bisphosphonate therapy in again the CRPS 1 patients, which was a systematic review. It showed that the bisphosphonate reduced pain intensity over 4 weeks and at 12 weeks of follow-up. So I have compared various bisphosphonate agent based on the RCTs and its efficacy and how is it like in whether it is approved or they are just used off-label. So naridronate based on 5 RCTs, there's in 73% of the patient, there's more than 50% pain reduction. This is approved in Italy in 2014. There's a clodronate based on 1 or 2 RCTs. There was a significant VAS score reduction, but they are not approved in US. Alendronate from the two available RCT showed modest benefit, but it is approved, but mainly in osteoporosis. Palmidronate from 1 RCT, it has a similar efficacy to neridronate, but they are approved for other indications, not so for CRPS per se. Zolendronate has a limited data because they have not been extensively studied. So out of these all, neridronate has the strongest evidence base for CRPS. In bisphosphonate plays a major role if we give importance to the timing of the therapy. So optimal window for bisphosphonate treatment is 3 to 6 months for best possible outcome. And dystrophic phase, because of the dystrophic phase, which has proven to show maximal response. Early phase, there has modest benefit in because of the intense inflammations and inflammatory markers. And in chronic phase, there is also a poor response to bisphosphonates because of the atrophic and fibrotic changes which are irreversible. So here the early recognition and starting of treatment plays a crucial role for the success of the bisphosphonate therapy. Based on the study, we have outlined a algorithm for CRPS management. This was followed as like in early phase, which is within 6 months, always multimodal therapy with NSAIDs and corticosteroids, along with it, early physiotherapy should be instituted. If the response is inadequate at 3 months, definitely add a bisphosphonate. Because the optimal window is 3 to 6 months. And the bisphosphonate of choice is naridronate, which is IV, 100 mg injections for 4 doses, or can use clodronate IV, 300 mg per day for 10 days. Along with the pharmacotherapy, continue with the intensive physiotherapy, occupational therapy, and mirror therapy and desensitization modality. If there is still a suboptimal response even after addition of bisphosphonate. Go for interventions like sympathetic block, IV ketamine infusion, spinal cord stimulation. So functional restoration remains a cornerstone. Bisphosphonate definitely reduces pain so that we can focus on the rehabilitation part. Uh, so the challenges which we have seen from the various studies we have encountered had as the heterogeneous study population, and there were variable dosing regimen, and there is a limited CRPS 2 data to prove bisphosphonate as a treatment option, and lack of long-term outcome or this is under recognized in India. So availability and cost issues. So future research, we need uh, biomarker-driven patient selection, dose response optimization, India-specific we need a India-specific real-world data and cost-effectiveness analysis. Indian guidelines have yet not been like very much. We are using it. We are relying on the international guidelines. Yeah. So for in I'm discussing about the international and Indian guidelines for CRPS management. So ULR has strongly recommended bisphosphonate with the sufficient evidence as the agent of choice in CRPS 1. In ISP, International Association of Study of Pain in 2022 to 2024 has recommended early intervention has a critical role, but bisphosphonate can be used as an adjunct. Indian Association for Physical and Medical Rehabilitation have instituted a multimodal approach for along with the physiotherapy, pharmacotherapy, interventions, and psychotherapy. So Royal College of Physicians in UK, they recommend pamidronate 60 mg IV should be considered in patients with CRPS less than 6 months. It this was based on only one good RCT. So Germany they strongly recommend the bisphosphonates for pain, function, and patient self-assessment in CRPS. But
Just a second. I think Ashwin is trying to share screen. We are not able to see Anjali's screen. Anchal, please ask him to stop sharing his screen.
Yes,
Na?
sir. I called him and he is stopped
What
now.
he's doing, I don't know. Because all of a sudden the Anjali
Ashwin,
part has gone.
yeah, Ashwin,
So
please
ask him to just
stop
stop.
sharing your screen. Ashwin?
Dr. Anchal, you can, I think, do something for
I'm
this.
trying from my end. Stop. Okay. Yeah.
Yeah. Okay.
Dr. Anjali, please continue.
Germany has recommended bisphosphonate as a treatment, but they have not individualized a drug. Like it's up to us. It's up to the clinician to decide on which agent to use. So EULAR and ISP and Italy, they have strongly recommended naridronate as agent of choice with multimodal approach should be along with the therapy, and naridronate is the only approved agent by these bodies. Also, American Academy of Family Physicians have shown that bisphosphonate and short course of oral corticosteroid has significant will like significantly improve pain in patients with CRPS with level B evidence rating. So based on the JDAD score, which is for the quality assessment based methodological quality assessment. So they have outlined like two studies have the highest JDAD score, which was Varina with IV naridronate in 82 patients. It was a double-blinded RCT. And the second study was with IM naridronate in 2021. The moderate quality JDAD scoring of score 6 was given to young study with pamidronate, and Robinson study for again for pamidronate in 27 patients. Other study had a low JDAD score. So this is the similar summary of the JDAD score and the number needed to treat based on the various published studies of role of bisphosphonates in CRPS. So over the years, with the evolution of the treatment modality and the agent of choice for CRPS, I have compiled one timeline, like from 1990 to 94, based on the case reports era. There were small case series and reports, so they were of very low evidence. Over the years, like 97 to 2004, first RCT came with pamidronate, alendronate, and clodronate, and but the sample size were low, and responders were 40 to 60, and evidence was low to moderate. Then came the landmark trial, which was in 2013 with IV naridronate. This showed that the naridronate was a treatment of choice with a high level of evidence. Another, the subsequent study came by the same Verina et al. In 2021 with IM naridronate. This also showed a high level of evidence. So the recent one was 2024 and 2025 meta-analysis and long-term real-world study by Ferraro et al. In 2025. And another was with G. Adami with 3 years of follow-up. So evidence was moderate to high. So this is how we have come to the level of evidence and over the years. And we have one only naridronate with as a best agent as per the studies, but because of the limited availability and the cost issues, we are not we are yet to have in future, like maybe we can have naridronate as a drug for CRPS management. The key takeaways are the moderate for evidence, moderate certainty for short-term CRPS pain relief, limited long-term data. They act as a anti-inflammatory action, not just as a bone anti-resorptive. And timing of administration is always important. 3 to 6 months is the window period for optimal benefit. And number needed to treat is 2.4 for more than 50% reduction in pain. Agent has naridronate has the strongest evidence, and IV route is always preferred than the oral route. Safety wise, they are well tolerated. No adverse serious effects have been seen in various RCTs. Multimodal, along with the pharmacological, should be a comprehensive rehabilitation and comprehensive modality of treatment should be instituted. And predictors are the male younger population and early treatment, and lower limb involvement has a better response. So with this, I end my slide presentation. Thank you.
Thank you, Dr. Anjali. Commendable job. Actually, you compiled many studies together, and the information you shared was really too much to
No, Dr.
absorb.
Anchal, I must compliment
Yes.
Anjali and Mohit because in our setup we don't have any data regarding treatment of CRPS with bisphosphonates,
Yes.
and both of them worked very hard and take a lot of time and to find out some evidences, and we have never seen such kind of comprehensive use of bisphosphonates in CRPS. And but we were discussing the key takeaway is in our setup, we have to talk in our setup what we are doing. Like we have to start it early. There is no use. You might be seeing many case report that somebody has used in 15 years, 20 years, one single dose. These are all not done. Secondly, the dose is always has to be given early and IV or IM, and even if oral, then daily dosing for 4 to 6 weeks rather than treating it like a monthly dose or weekly dose. That is not going to work because the therapeutic window is narrow. So, like in our setup, we can use zolintronic acid, which is available IV. Like we have used in two patients for 4 gram IV stat. So, but using like a routine osteoporosis drugs, and that too monthly or weekly is not going to work. And particularly, it will work in CRPS 1 only. CRPS 2, we don't have any data to suggest. And so early start, high dose, either oral or IV, whatever is available with us, and CRPS 1. I think that is the key takeaway from all this discussion.
Yes. So we have
Otherwise,
the
it is no use.
CRPS use of this bisphosphonates in pediatric too. Let's hear the other speaker,
Yes,
and then we
yes,
can discuss. Anjali, you can
yes.
stop screen sharing, and
Okay.
Dr. Ashwin, you can once she stops, then you can start sharing your screen. Dr. Ashwin, I think you were having some. So he'll be presenting in the the role of bisphosphonates. I mean, it's just a case report, but still they have used bisphosphonates in pediatric age group. So we will see that. Okay. So the bisphosphonates, this is a presentation regarding the when bisphosphonates were used in refractory CRPS. These are two case studies. I think we can skip over the CRPS, what it is, we all know, and why Dr. Anjali has very well explained why we use bisphosphonates, what is the reason behind it. So the pediatric cases, they says that in adults, it has really shown good benefits whenever used, but pediatric CRPS also, they have incidence from 1.2 to 1.3 per 100,000 children, especially in girls. The standard therapy, of course, is physiotherapy, psycho, and pharmacological treatment, but IV bisphosphonates has shown benefit in adults, but data is still scarce in children. So, and prior pediatric evidence before these studies were just limited to some case reports. So, in this paper one, they studied 16 patients. Out of them, 15 were female and one male. The age range was 4 to 14 years, CRPS type 1. The disease duration before bisphosphonate treatment was started was median was 11 months, but range was 5 to 18 months. So they started at least bisphosphonates in the same year of origin of symptoms. Their baseline VAS intensity, functional disability, they all recorded. Their school attendance, all baseline parameters were recorded. And what they did was all the 16 patients received bisphosphonates. Out of them, 11 was given zolidronic and palmidronate was given to 4 patients. Actually, they started from zolidronic acid in 1 patient and switched to palmidronate. And the reason they written was because of the this febrile reaction, which like not able to tolerate it. So when they used zolidronic, the dose was 0.025 to 0.04 milligram. Maximum was 4. They infused it over 30 minutes. They gave 2 doses, and median interval was from symptom onset to treatment was 11 months. And palmidronate 0.72 to 1 milligram per kg. Infusion was 4 hours, and median number doses were 3. And they monitored baseline BMD, renal function, calcium, acetaminophen, NSAIDs, and calcium supplementation when indicated. So a primary outcome was global impression of change. And then secondary outcomes or pain intensity, same thing, functional disability, school attendance, and also they used how much opioids were used before, along with antidepressants. And we can see in everywhere they saw the improvement. Like, for example, pain intensity was 8 and it reduced at 16 months to 4. Functional disability was 18 and it reduced to 6. School attendance also improved. And the use of opioids, 9 patients were using opioids and it reduced to 1. And an antidepressant also from 9 to 4, gabapentinoids, they all left at follow-up, and NSAIDs also. So significant improvement in with respect to functional disability, reduction in pain, and use of medication for pain management. And the similar, as Dr. Anjali presented, similar side effects like flu-like symptoms, fever, headache, myalgia, and serious side effects, there was no reported. But okay, so Dr. Ashwin is saying that he'll present. Dr. Ashwin, can you hear me?
Yeah, I'm ready, madam.
Okay, so you can take over.
Okay,
Sorry.
Yeah.
Do you want to start from,
I'll start from the first, madam. I'll start from the first.
Okay. Do you want to start from the pediatric cases? Because it's already...
Yeah, madam. I'll start, madam.
Okay.
It's displaying, no?
Yes.
Yeah, shall I start?
Yeah, please.
Yeah, sorry for the late interruption. And actually, I'm Dr. Ashwin. I'm an Onco anesthetist and pain physician. And my topic is first of all, it's a complex regional pain syndrome. And usually, please see the red lines and red highlighted lines. The bisphosphonates has emerged as a potential therapeutic option due to their effect on bone metabolism and inflammation. And my study is on 2 studies evaluating bisphosphonates in refractory CRPS. One is pediatric case series, another one is meta-analysis. And next one is, first of all,
Dr. Ashwin, will you share your screen, or you want me to share the screen? Because I don't know which.
I'm sharing, no, madam. It's coming, no?
I have to stop sharing.
It's coming?
Yeah, it's coming. It's coming.
Yeah, no problem. And it's okay, no?
Yes.
It's moving, no, madam, slides, sir?
Yes.
Yeah, okay. CRPS is a regional pain that is disproportionate to initial injury or inciting events, and it commonly follows trauma, fracture, surgery, or immobilization, but may also occur without a clear precipitating cause. And just a mention about clinical features of CRPS. One is hyperalgesia, allodynia, and autonomic disturbances and motor involvement. And pathophysiology of CRPS is peripheral and central sensitization and neurogenic inflammation with dysregulation of sympathetic nervous system. And the standard treatment approach is physiotherapy, psychological intervention, and NSAIDs and interventional procedures. And why we consider bisphosphonates is, just see the highlighted lines. It inhibits osteoclastic activity with reducing abnormal bone resorption, and it also decreases inflammatory cytokine release. And first, I'm going into the first study. There's a pediatric case series. that took place in 2021. And this pediatric CRPS, the incidence is 1.2 to 1.3 per 1 lakh children, and it's more common in girls, frequently affecting lower extremities. And this adult CRPS studies are there with bisphosphonates, but data in children is very scarce. So I'm presenting it. And the patient characteristics is, first is total patient analyzed is 16 with female 15, male 1. Just see the highlighted red lines, red highlighted points. And age range from 4 to 14.3 years. And it's a CRPS type 1 I took. And the duration of CRPS is median is around 11 months and interquarantine range is 5 to 18 months. And before treatment of bisphosphonates, the baseline pain intensity is median is 8 and IQR is 7 to 9. And baseline functional disability score is median is 18. And physical disability score is baseline physical disability is functional disability index is classified into 3. From 0 to 12 is minimal. From 12 to 28 is moderate, and more than 28 is severe. And FDI of less than 12, only 1 patient. The remaining were in moderate or severe. And regular school attendance is 9 before treatment of bisphosphonates. And interventional details is just mark the highlighted lines. Zoledronic acid, 11 patients were given. Pamidronic acid, 4 patients were given. 1 patient switched from zoledronic acid to pamidronic acid because of adverse effect. And this zoledronic acid, the dose is 0.015 milligram per kg in 100 ml saline was given, and infusion duration is 30 minutes and median number of doses is 2. Median interval from symptom onset to treatment is 11 months. And second one is pamidronate, 0.72 milligram per kg in 250 ml saline is given, and infusion duration is 4 hours and median number of doses is 3. And monitoring baseline bone mineral density, renal function test, calcium monitoring, acetaminophen, NSAID, calcium supplementation were indicated. The statistical analysis for dichotomous variable Fisher-Exact test was a statistical analysis. For continuous variable T student test was taken. And this PGIC, that is patient global impression of change, is the primary outcome. And this, the cutoff value of 84% more is normal. And the primary outcome is patient global impression of change that I previously told. And this 8/16, that 8 patients out of 16, that is 50% experiences PGIC of more than 84. The next one is 50% reported PGIC of more than 84 to 100. 31 patient reported PGIC of 50 to 67%. 19% reported PGIC of less than 30%. This is the primary outcome. Next, the secondary outcome is, one is pain intensity. Before treatment, the median NRS was the pain score, was 8, and follow-up NRS is 4. Functional disability index, the before treatment is 18 and after treatment is 6. Just mark, see the highlighted red lines, and the school attendance is before treatment is 9, follow-up treatment is 15. And medication use of opioid before treatment is 9, after bisphosphonate treatment is 1. Antidepressant before treatment is 9, follow-up is 4. Gabapentinoids before treatment is 12 and follow-up is 0. And NSAID before treatment is 12, follow-up is 1. And this the tabular column, the pain intensity follow-up is 4, FTI is 6, minimal FTI less than 12 is 11, role of function is 15. Almost because of bisphosphonates, pain intensity, FDI, physical disability, role function, everything is improved. And these are the opioids before bisphosphonates and afterwards. See the tabular column, the opioid before bisphosphonates 9, after it's 3 and 1, and antidepressants 9, after bisphosphonates it is 3 and 4. Gabapentinoids before treatment is 12, after it's 0. NSAID before treatment is 12, after is 1. It is after bisphosphonates, the opioid, antidepressant, gabapentinoid, NSAIDs, all the doses reduced. And the adverse events, the thing is, in bisphosphonates treatment, the adverse event is increased. 13 events out 13 patients got adverse effects like flu-like symptoms, fever, headache, and myalgia. But these are all not serious, non-serious adverse events. The serious adverse events like hypocalcemia, renal impairment, osteonecrosis of jaw is non-reported. And finally, the key results. See, the pain intensity is reduced from 8 to 4 after bisphosphonates. Functional disability is reduced from 18 to 6. Regular school attendance increased from 56 to 94. And marked reduction in opioid and adjuvant medication use is seen. And bisphosphonates infusion is well tolerated without serious adverse events. And the safety and tolerability, this IV bisphosphonates is well tolerated. 13 out of 16 patients got non-serious adverse events like flu-like symptoms, serious adverse events not seen like hypocalcemia, and all reported adverse events resolved spontaneously without any additional interventional medications. No serious adverse events were reported. And the conclusion of the study is it's a clinically meaningful study, and significant improvement were observed in physical function and disability score, and marked increase in regular school attendance were seen. A reduction in need for analgesia and adjuvant pain medication is seen. Half of the patient as clinical improvement is patient global impression of change of more than 84%. And one of the disadvantages of studies due to retrospective study design, it's a small sample size of only 16 patients were taken. So more prospective studies is required. This is the first study, and I completed the first study. I'm going into the second study, that is adult case report. Previous one is pediatric case report, and this one is adult case report. And this case report is taken in joint, bone and spine in 2017. This is a systemic literature review and meta-analysis of randomized control trial. It evaluates the efficacy and safety of bisphosphonates in patients with complex regional pain syndrome 1. And in this study, it's a meta-analysis study of multiple RCTs, and multiple studies were taken. And its inclusion criteria includes RCT and studies that evaluate the efficacy and safety of bisphosphonates and adult patients with CRPS 1. And the exclusion criteria is uncontrolled trials are excluded, and controlled trials without placebo, because all the studies are RCT studies compared between bisphosphonates and placebo. So the control trial without placebo is excluded. And this is the consent chart. First of all, 258 patients were taken, 131 patients from PubMed, and remaining patients from MBBS and Cochrane reviews were taken. Of 258 patients, 227 patients were excluded because of no bisphosphonates were in the study, and no CRPS according to international guidelines were in the study are removed. So totally 31 patients were taken. From the 31 patients, 26 patients were excluded because it's of no RCTs. So 26 patients were excluded. Remaining 5, among 5, 1 patient is excluded because not enough data is present. So finally 4 meta-analysis were taken. And the study design is conducted according to Cochrane Systemic Review Guidelines, and 2 reviewers independently selected studies and extracted data, and the methodological quality was assessed using JADAT score. JADAT score is a quality score that measures in meta-analysis. JADAT score of 4 or 5 indicates a good quality analysis. And in this study, the mean JADAT score was 4.5 plus 0.9 indicates moderate to good quality. Meta-analysis were performed using Review Manager 5. And just a minute. And the patient characteristics were 181 patients were taken, 90 patients in bisphosphonates category, and 91 patients in placebo patient. And mean patient age is ranging from 44.6 to 58.2 years, and mean disease duration is 3.7 to 21.6 months. All patients met international diagnostic criteria of CRPS 1. Okay. And patient characteristics and intervention details. And multiple bisphosphonates were evaluated across the trial. In previous studies, pamidronic and zoledronic acid only included, that pediatric case study. And this study, multiple bisphosphonates were evaluated. Alendronate, pamidronate, clonidronate, and nerindronate were evaluated. Treatment duration ranged from single infusion to 8 weeks. Dosing regimen differs between the trial. All bisphosphonates were compared directly against placebo. And the outcome measures, the primary outcome measure is pain intensity. Then previous pediatric case series, the primary outcome is patient global impression of change. Here, the primary efficacy outcome is pain intensity, that is measured by visual analog scale. Here, the classified pain as short-term pain assessment for 30 to 40 days one. The other one is medium-term pain assessment at 2 to 3 months. And the other outcome, like functional outcome, include mobility, pressure tolerance, and SF36 score. Score were included. SF36 score is a 8-scale score, and that includes physical functioning and bodily pain, physical health, and emotional viability, and etc. The adverse events are measured using relative risk, and 95% confidence interval were employed, and heterogeneity assessed using I2 statistics. And we evaluated the influence of each subgroup heterogeneity by forest plot analysis and chi-square test. This forest plot analysis is a graphical representation of multiple studies in meta-analysis. And the publication by was assessed by funnel plot analysis. This funnel plot analysis is also a graphical representation of a meta-analysis. And in this, finally, the key results, since the primary outcome is pain through visual analog scale, the final pain reduction is short-term VAS pain was significantly lower with bisphosphonates, and standard mean difference is minus 2.6. That means a good pain reduction is there, and 95% confidence interval is from minus 1.8 to 3.4. And the short-term pain reduction is statistically significant also. And the median-term pain outcome was calculated, and in that the standard mean difference is minus 2.5, and with 95% confidence interval is from minus 1.4 to minus 3.6. And the median-term pain reduction was also statistically significant. And the functional outcome varied between the studies. The improvement were noted in physical function domain of SF36. The quality of life improvement were seen in several SF36 domain, and in SF36 domain, the emotional and vitality domain show less consistent changes. And due to heterogeneity, functional outcomes were not pooled in meta-analysis. And one thing, this is the safety of bisphosphonates based on serious adverse events and non-serious adverse events. In treatment group of bisphosphonates, no serious adverse events were seen, but non-serious adverse events were increased compared to the placebo group. If you see that in the Manico trial, it is 1, and in Robinson, it's 7 compared to 2. In Varina, it is 3 compared to 0. In Varina, it is 21 compared to 12, and in total 32 compared to 15. Okay. The second, safety and tolerability of the study. Adverse events occurs in 35.5% of bisphosphonate patient. Adverse event occurs in 16.4% in placebo patient. The relative risk of adverse event is 2.1. That means more than 1 means in treatment group, the adverse event is more compared to the exposed group. So 2.1 is there's more chance of adverse event. And 95% confident interval of relative risk is 1.27 to 3.47. And adverse event differs for statistically the adverse event, the short-term pain score, the medium-term pain score, VAS pain score, and adverse event were statistically significant. But all adverse events are non-serious adverse events, and number needed to harm is 4.6. That means every 4.6 patient, the next patient is experiencing the adverse event. The common adverse events include mild fever, GI intolerance, erythema, and an infusion site discomfort. No serious adverse events were reported. And final conclusion and clinical implication is pain reduction was observed in both short-term and medium-term follow-up. Effect size were large and clinically meaningful. Functional outcome shows favorable trend, though heterogeneous. However, no serious safety concerns were identified. Adverse events are mild and reversible. Compared to the pediatric and adult influence, first is pediatric study. It's a retrospective case series of total number is 16, while adult evidence is systematic review and meta-analysis of 4 RCTs. And the outcome emphasis differs is pediatric measures PGIC with pain, function, school attendance, medication reduction, while adult meta-analysis focused on VAS pain at 30 to 40 days and 2 to 3 months. That is medium, short-term and medium-term pain. And pediatric cohort shows 50% major improvement. That is PGIC of more than 84. That is 50% of patient. That is 8 patient had PGIC of more than 84. And pain reduction is reduced from 8 to 4. While adult meta-analysis shows strong pain reduction with SMD of minus 2.6 and medium term is SMD of minus 2.5. And clinical takeaways is adult RCT evidence supports meaningful pain reduction versus placebo, strengthening rationale for use in selected patients. Pediatric data suggested potential improvement beyond pain. FTI is reduced and real-life recovery such as school attendance. And limitation of current evidence is pediatric evidence is limited to small retrospective case series with no control book, making casualty uncertain. And that's all. Thanking you.
Thank you, Dr. Ashwin. That was also indeed, really crux of review, and thank you for presenting it. Can we have Dr. Padmecha, Dr. Ashu, your comments?
Sure. So first of all, I do want to congratulate both the presenters. They did a very detailed analysis and they reviewed the papers very well. Couple of things about CRPS. I know it is not something that you see very commonly in your clinics and in your practices. The problem is that it isn't the patients as well as the providers, the primary care physicians, are not very aware of the existence of CRPS. So a lot of patients who have fracture or trauma, they continue to follow with orthopedic providers, but they are never referred to the pain practices. So it is important to try to make other clinicians aware of this entity, so they are referred to the pain physicians. That is one thing that we notice, that the more awareness there is amongst the providers, you will get more referrals of CRPS and you can catch them early. The other thing is, all these studies that are done, they are not done independently just using the bisphosphonates. These are the patients who are getting other multimodal pain management. So whether to say it is an only modality that we can use to treat CRPS is not correct. It should be used as an adjunct and start early on if you can. The other thing is long-term side effects with bisphosphonates, we are not aware. These are all short-term studies that were done, 18 months follow-up. So whether there are jaw necrosis, osteonecrosis, and other long-term side effects for bisphosphonates, we are not aware of that. When you're managing CRPS, try to utilize the 4 pillars that I say in CRPS management. One is, when these patients come to you, educate them about this condition. When the patients are educated, they are able to cope with it much better. The other thing is to utilize PT, physical therapy, not just exercises, but you have to do desensitization techniques, you have to do mirror therapy, anything that you can implement that will control the pain and keep the functionality of that limb. So it is very important to initiate physical therapy in the beginning. Then obviously the major role is our pharmacological therapy, that we are going to utilize multimodal approaches with NSAIDs when there is inflammatory space, or steroids when there is inflammation. And you can utilize gabapentinoids and tricyclics and different opioids if the pain is really uncontrolled. So that is the pharmacological management. Interventional option, although most of the literature says you can start everything else and then try intervention, I would say start early with sympathetic blocks, because they help these patients control the pain even for a short period of time, so they can participate in physical therapy. So utilize the sympathetic blocks. If you're doing sympathetic block, bring these patients early on for follow-up to your clinics. So as soon as the pain comes back, bring them, repeat the sympathetic blocks if you're doing them. Not every patient will respond to sympathetic block, only the ones that have sympathetically mediated pain will, but utilize the blocks early, whether you're doing sympathetic block or solid block like a upper or lower extremity block. These patients are able to participate in therapy. So that is the third aspect. Ketamine infusion, I don't know if you are doing it, but it shows a significant role in long-term CRPS patients where there is central sensitization. So you can definitely make an impact by using ketamine as an option. So don't forget all these options that you have. And obviously neuromodulation has a role, whether it is spinal cord stimulator or dorsal root ganglion stimulators, they have a role in management. Most of the literature evidence shows that they can help for 5-7 years. But those are the important points. And we utilize psychologists in management of these patients too. I'm not sure how much is the for patient to receive a psychological management. It is difficult to do that in India, but definitely as a pain physician, you should talk to them about behavioral modification and expectations. You are not going to do what you were doing 10 years ago. So the patient understands that the pain is going to impact them in different ways. So as a pain physician, you can guide them. I think that's where you have to think of multimodal management in this condition and definitely talk about more awareness. But I do congratulate for bringing this topic. It is really important. Thank you, Anjali.
Thank you. Ashu sir, I'm just in the continuity, and I know you mentioned many key home takeaways, but anything you want to add from the previous?
So important point is exactly, I agree with ma'am that it is a multimodal therapy and you can't jump to using bisphosphonate as a first line therapy. So you have to start early and yes, and like in our practice also, we start to do sympathetic block early rather than waiting for this and found very good results. In CRPS, one we use steroid early for presuming that it is an inflammatory condition. So we'll love to use steroids, sympathectomy, and all these kind of modalities, physical therapy, and everything before we jump onto bisphosphonates. And if we think that these things are not helping, then we definitely do a bone scan for a late phase reuptake. And if that is positive, we start using bisphosphonates. But bisphosphonates use IV rather than oral doses in a single shot of 4 gram and may be repeated after 2 months if required. So definitely we have to use all the options that are available and use them early rather than waiting for things to flare up. And yes, if things are not responding, then bisphosphonates is a very good therapy that we look at. And with the given options available to us, this is what we use.
If that's what we were discussing last time, like in refractory CRPS, if you can add it as an adjunct, if already you are doing
Yes.
everything and the doses required would be higher. That's
Yes.
what the
So,
thing.
so important message exactly that we was talking last time also. Like the dose that you give in osteoporosis is like 75 milligram weekly or 150 monthly. It doesn't work like that way.
Mm.
So even if in a studies, if you see you are giving oral doses, you have to give daily for 4 to 6 weeks, maybe sometimes 8 weeks. So that is the thing. If you can, like IV zoledronic acid is available, you can give nicely, and it works wonderfully very well. I have experience of
Well, those stuff or
two
going to
cases.
repeat it?
You can repeat it after 2 months. So
Your protocol, Dr. Ashwin?
so this is how it
Dr. Raj,
works. But
your voice is breaking. You have question? You were.
I was
your
asking
usual
Dr.
dose are not
Ashwin,
going to work.
what's their protocol about administration of Gelantrin or the other drug?
Dr. Ashwin is asking your protocol in patients with CRPS.
Dr. Ashwin. Dr. Ashwin.
Dr. Ashwin. Dr. Ashwin?
Yeah, sir.
What's
When
your
you-
protocol of administration? It's a single time or you
What's your? Sir, I can't understand.
So
What's
he's
your?
asking in your institute, wherever you are practicing, what's your protocol of using bisphosphonates if the patients come with CRPS? As an adjunct, of course.
Yeah. Yeah, if CRPS, I'll go with multimodal therapy, madam.
No,
Yeah,
But if you have to use bisphosphonates,
more-
what's your protocol?
Yeah, bisphosphonates we are not using for CRPS, madam.
Okay. Okay. So that was the question that we can add it as in
Yeah.
refractory cases. I would invite any of
Yeah.
the attending, who are attending this journal club, they want to pitch in
Ma'am?
their comments or.
Hi, ma'am.
Hello, Dr. Deep. Yes.
मैम मैं गाड़ी चला रहा हूँ वीडियो इसलिए बंद है
Okay.
मैंने एक बार देखा मैम आईपीएससी में एक पेशेंट